Good afternoon, everyone. I am Ann Wong with the Illinois Chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar, Update on Meningococcal Disease Epidemiology and Meningococcal Vaccine Recommendations. Today we are joined by Dr. Amanda Cohn from the Centers for Disease Control. We will be offering continuing education credit worth 1 hour. ICAP is sponsoring it in accreditation by the Illinois State Medical Society to provide continuing medical education for physicians and for registered nurses. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Dr. Cohn will answer them at the end of the presentation. Dr. Cohn serves as Executive Secretariat of the Advisory Committee on Immunization Practices and Senior Advisor for Vaccines for the National Center for Immunization and Respiratory Diseases. Dr. Cohn came to the CDC in 2004 as an Epidemic Intelligence Service Officer and joined the Meningitis and Vaccine Preventable Diseases branch in 2006, where she focused on prevention and control meningococcal disease. She is board certified in pediatrics and is a fellow of the American Academy of Pediatrics. She obtained her medical degree from Emory University School of Medicine and completed a residency in pediatrics at Boston Children's Hospital and Boston Medical Center in Massachusetts. Please join me in welcoming Dr. Amanda Cohn. Okay, I'm going to turn it over to Dr. Cohn now.
Great, thank you. Can everyone see my screen? Okay, great. So thank you for having me today. I always appreciate speaking about one of my favorite topics, both because of its importance and because of the complexity of this. So I will be giving you an update on meningococcal disease epidemiology and on the recent meningococcal vaccine recommendation. I have no conflicts of interest or disclosures. So the objectives of this talk are for me to give an overview of meningococcal disease, recent epidemiology, and describe the current ACIP recommendations for meningococcal vaccines. I'm also going to talk a little bit about understanding the rationale for the current recommendations and the inherent challenges of meningococcal disease prevention and control. And we'll finally end up by talking about different types of recommendations, including routine and non-routine recommendations. So Neisseria meningitidis is spread person to person. The incubation period is short. It's usually 3 to 4 days with a range of 1 to 10 days. But this is actually one of the reasons why we think one of the challenges with meningococcal vaccines working really well, which we'll talk about in a little bit. The signs and symptoms include fever, headache, stiff neck, and the symptoms are rapidly progressive. So frequently, meningococcal disease looks like influenza or somebody just being sick with a bad viral illness, and can frequently be not caught on the first visit to the physician, and then the symptoms get significantly worse. Treatment is rapid diagnosis and antibiotics. There, however, is still a 10 to 15% case fatality rate even with antibiotics, and there's an additional 11 to 19% who have long-term sequelae. And most disease occurs in healthy persons. This is a picture of Neisseria meningitidis. There is a capsule, and it's the outer capsule that describes the serogroups. So we have serogroups A, B, C, Y, and W disease, which cause most disease globally. And those are the targets for the conjugate vaccines. We also have outer membrane proteins. So we have, you can see here these proteins, which are not part of the capsule, but on the outer membrane. And those are what we target for the serogroup B vaccines. And we'll talk a little bit about the reasons for this in future slides. So what leads to invasive disease? There are kind of three different things that influence, that we can contribute to invasive disease. There's pathogen virulence factors, including capsule, adhesins, nutrition acquisition factors, and endotoxin release. There's also host factors, deficiency in terminal complement component pathway, asplenia, immunosuppression, genetic risk factors, and population factors such as household exposure, crowding, demographic and socioeconomic factors, and smoking. However, even though we kind of know all of these things can contribute to meningococcal disease, most cases occur sporadically with really no known reason or cause for those cases occurring. Only 2 to 3% of cases in the US occur during an outbreak. And I think that's a misnomer because we hear about meningococcal disease outbreaks, and so we hear about those cases, but they actually compose just a small number of cases. Okay, so this next slide is a slide that shows the meningococcal epidemiology. And what you can see here, this is incidence per 100,000. So in the 1930s and 40s, we had really high incidence of meningococcal disease. And these actually were mostly serogroup A until the end of the 1940s. What you see after that, since about 1970, are much lower grade in terms of incidence. We're not seeing 12 per 100,000, but we've seen typically 1 to 2 per 100,000. And you'll see we used to have these up and down cycles of meningococcal disease where we'd have some years where it was higher and some years when it was lower. And around the year 2000, all of a sudden we started to see much lower rates of meningococcal disease. And so now we're at historic lows. And when we first started to see these lower rates, we thought that we would start to see increases in the near future. But we've really seen these historic lows for many, many years. And what we believe is that while the current MenACWY recommendations for adolescents have contributed to disease rates staying this low, they really are not entirely due to the recommendations. We don't think we're seeing vaccination be the cause of these lower disease rates. And part of that is because, as you can see in this slide, we've actually seen serogroup B decline at the same rate as serogroups C and Y, which are contained in the conjugate vaccine. Another reason is that we saw a lot of these declines occurred before coverage got high. So in 2005, 6, and 7, we had very low coverage with serogroups with MenACWY. And it's really only in recent years that we've had this high coverage. And we've seen sustained low incidence, but we really think that we don't quite understand why we're seeing such low disease rates, but vaccination is not the primary reason. Even though we do see these low disease rates, we still see this peak in late adolescence. And so what you see now from this next slide shows serogroup B, C, and Y incidence by single year of life. And you can see this peak in late adolescence that we targeted MenACWY to preventing, and this is why we implemented the booster dose, was when we realized that MenACWY wasn't going to last through this peak, we felt we really needed to make sure kids got revaccinated at age 16. What you also see is that you continue to see this peak for serogroup B, and serogroup B causes a high proportion of cases now in this adolescent age group. But if you look at the incidence, it's still incredibly low. So while most of the cases we see in adolescents are serogroup B and are not prevented by the MenACWY routine recommendation, we still have very low incidence. And this is an important slide, which I think a lot of even pediatricians may not recognize, which is that we actually have much higher incidence of meningococcal disease in infants less than 1 and in 1-year-olds than we even do in adolescents. And we currently don't recommend MenACWY in this age group, and there's several reasons. One of those being a majority of the disease in this age group is serogroup B. And so we would be preventing a much smaller proportion of disease with MenACWY vaccines. But additionally, when you give these vaccines in infants, you need a 4-dose series. And so by the time these kids complete their series, the disease risk has already dropped dramatically, and the duration of protection is not that long. So we recommend MenACWY vaccines for just high-risk younger kids and infants. So now I'm going to talk about the conjugate vaccine recommendations in the US. So we have 4 meningococcal conjugate vaccines, and I'll just speak very briefly about each of them. Menactra is a conjugate vaccine. This was the first licensed vaccine conjugated to diphtheria toxoid, and that's MenACWY, and that's licensed for ages 9 months to 55 years. Menveo is a conjugate vaccine. It's conjugated to CREM197, so it uses a different conjugated protein. This is now produced by GSK. It protects against the same serogroups. It's licensed down to 2 months of age rather than 9 months of age. Still has that peak at 55 years. Menhibrix is conjugated to tetanus toxoid, and it's a GSK vaccine. It's serogroup C and Y, but it's also a combination vaccine with Hib vaccine. So this was really targeted to infants, 6 weeks to 18 months. But since there's no routine recommendation for infants in this age group, it's really high-risk infants that this vaccine would be helpful for. We also do have Menimmune, which is the older polysaccharide vaccine, which is not a conjugate vaccine against serogroups ACWY. It's licensed in greater than 2-year-olds. It's used very rarely in the U.S. now, really in targeted groups in older adults for whom the conjugate vaccine is not licensed for, and the Menimmune vaccine is still pretty protective against. So the current ACIP meningococcal recommendations for MenACWY vaccines are for routine immunization of all adolescents ages 11 to 18 years, giving the first dose at age 11 or 12 years, and that recommendation has been in place since 2005. And then in 2009, a booster dose was recommended at age 16 years due to substantial waning of immunity 3 to 5 years following immunization. We also recommend routine immunization of persons greater than 2 months of age at increased risk for meningococcal disease. So this includes persons with medical conditions such as asplenia, complement component deficiencies, and there's a recent recommendation to include persons with HIV in this group. It also includes special populations such as unvaccinated first-year college students living in dormitories, military recruits, and microbiologists with routine occupational exposure, and persons who travel to or reside in countries where disease is hyperendemic or epidemic. And this last group was really to prevent serogroup A meningococcal disease in persons who were traveling to the meningitis belt in Africa. Fortunately, since 2010, they've been doing mass vaccination with a serogroup A meningococcal conjugate vaccine, and we've seen drastic reductions in serogroup A disease. And so while we still recommend serogroup A vaccine, quadrivalent vaccine for persons in West Africa, and it's actually a requirement for persons traveling to the Hajj, we really have almost wiped out serogroup A meningococcal disease in the meningitis belt. The final really important group that's recommended for immunization is for outbreak control. And so the age group for using MenACWY can be expanded to control outbreaks, and we've seen that recently in the past couple of years. Particularly, we've had some serogroup C outbreaks among populations of men who have sex with men in Chicago and New York City, and there's currently an ongoing outbreak in Southern California. So then we expand our target, our recommendations to include those persons. So the booster recommendations at age 16 are a little bit more refined than what I just described in the prior slide. For adolescents who receive the first dose at age 13 through 15, a one-time booster dose should be administered, preferably at ages 16 through 18 years before the peak in increased risk. However, for persons who receive their first dose of meningococcal vaccine at or after age 16 years, those groups do not need a booster dose. And I think from what we can see in terms of immunization coverage and uptake, we're really seeing most adolescents get vaccinated now in that 11 to age 12-year-old age group. For the first several years of the recommendation, we saw it more generally dispersed throughout adolescence. And so this was to make clear that you really only needed that second dose if you got the first dose at a young age. We also have recommendations for revaccinating persons at prolonged increased risk. So infants and children with chronic medical conditions that are recommended for vaccination, including persons with asplenia, complement component deficiency, and HIV infection, microbiologists, which probably wouldn't include that many children, and persons who travel to or reside in countries with where Neisseria meningitis is epidemic. So if 5 years have passed and you're still in that country or traveling back and forth to that country, you would be recommended for revaccination. So in the young age group, 2 to 6 years of age, remember I said that the conjugate vaccines, the duration of protection is even lower in those, shorter in those age groups. We recommend revaccination at 3 years, and then revaccination at 5 years for persons who were previously vaccinated if they received their last vaccine at age equal to or greater than 7 years. We have one more recommendation, which is really to target people who are at extreme high risk for meningococcal disease. And for people who we kind of know conjugate vaccines, the first dose doesn't work as well. So we recommend that persons with asplenia, persistent complement component deficiencies, or HIV infection receive a 2-dose primary series administered 2 months apart, and then receive a booster dose every 5 years. And this is in response to data that shows that people with these immunocompromised conditions don't respond as well to a single dose of conjugate vaccine as a healthy population. So this slide demonstrates how we've seen serogroups B, C, and Y decline over time, but it also shows you how we've seen increase in coverage with MenACWY among adolescents aged 13 to 17 years. So the vaccines were licensed in 2005, recommended in 2006. But we had pretty, really good uptake given that this is an adolescent vaccine, but it took several years before we had over 60% coverage, and now we're actually close to 80% coverage with these vaccines. And that's why we really think that coverage is contributing to this nadir continuing, but likely didn't contribute to the really large declines in disease you saw before coverage with this vaccine. And this is a slide to demonstrate that we have seen really good impact in this adolescent age group. So among 11 to 19-year-olds, if you go back and remember that coverage slide from the last slide, when we started vaccinating, incidence was 0.27, and it's actually serogroups C, Y, and W disease in this age group have declined to 0.07 in 12 and 13. And if we updated that to the last 2 years, it would be the same, if not even lower. So that is an incredibly low disease incidence we're seeing in this group. That was at higher risk than the rest of the population at the time we implemented that recommendation. At the same time, what we're not seeing as much is a widespread impact on herd immunity. So for example, if we look at disease in other age groups, like persons greater than 20 years old who are not recommended to receive this vaccine, we saw lower disease incidence in that age group 10 years ago, but we really haven't seen any sort of statistically significant declines in that age group like we've seen with persons who give the vaccine. So while with other conjugate vaccines we've seen widespread herd immunity, like with pneumococcal and Hib vaccine, we really believe conjugate vaccines, the goal is to protect the individual, and we don't have an expectation that we'll see widespread herd immunity. Although in an enclosed population, like on a college campus outbreak or something, you might see some herd immunity. So adolescent MenACWY vaccine reduced the burden of meningococcal disease caused by serogroups C and Y. However, a booster dose of MenACWY is necessary at age 16 to provide protection through late adolescence. Our current uptake with that booster dose is about 30%, and that recommendation has been in place for a couple of years, or for 4 or 5 years now. Herd immunity has not been seen in the United States, as was demonstrated with MenC conjugate vaccine and with MenA conjugate vaccine in sub-Saharan Africa. And I think that's for 2 reasons, both because in both of those situations we had mass campaigns where they vaccinated an entire population, ages 1 through 29, in Africa, and ages 1 through 18 in the UK, very, very rapidly. But also I think these monovalent conjugate vaccines for meningococcal disease seem to be working better than what we're seeing with this quadrivalent vaccine. However, the US really needed a quadrivalent vaccine because we did have multiple serogroups contributing to our disease burden in the country. So now I'm going to move on to talk about the remaining burden of disease, which is meningococcal B disease. And this is where our what to do from a vaccination perspective has been really challenging. So serogroup B disease in the US has also declined over the last several years. And I think we've had some really high-profile outbreaks of serogroup B disease, but even in the setting of having recognized outbreaks, we still each year see fewer and fewer cases. So overall, in the U.S., among all age groups, we see fewer than 400 cases in the U.S. now of serogroup B disease. What we do see, however, is that as serogroups serogroup C and Y are declining, serogroup B disease is causing a higher proportion of our overall cases, especially in adolescents. So this is a slide we showed before, but I just wanted to highlight that serogroup B incidence is highest in infants less than 1, for which we don't have a licensed vaccine right now. But it's also higher among adolescents in this late adolescent age group, for which we now do have licensed vaccines, which I'll talk about in a minute. When we talk about meningococcal B recommendations, one of the first things that the ACIP considered was whether or not you should consider recommendations for all 18 to 23-year-olds, or whether or not you should consider recommendations just for college students. And once again, we have these high-profile outbreaks over the last several years among college students. But what we really find when we look at our surveillance data is that our disease incidence among all persons is 0.14. It's actually, we see less disease among college students than we do among non-college students in this age group. And I think, these are small numbers, and so, they could change over time, and it could be different in different years. This is a 4-year period. But I think part of the reason that this makes sense is because a lot of people who may not be in college may have a lot of other behaviors and situations that we think put them at increased risk, such as social behaviors, but also there's this general, well, we haven't defined these as risk factors. There's generally a sense that displaced adolescents, adolescents who are living in homeless shelters or even jails seem to have there seem to be more cases among students, among adolescents in that age group who have some of those risk factors. We also know that risk factors such as smoking, we've been not drinking per se, but very social activities can put persons at increased risk. Meningococcal outbreaks are rare, as we've talked about before. However, outbreaks are more likely in older children and adolescents. We've had 9 serogroup B meningococcal disease clusters and outbreaks on college campuses since 2009. And in these outbreaks, we've seen a 200 to 1,400-fold increased risk for students during the outbreak period. So while college students in and of themselves may not be at risk, we definitely think outbreaks are more prevalent on college campuses than they are in other settings, and that puts these college students at increased risk. We also know that outbreaks have a really large impact on the communities in which they occur. So these meningococcal disease outbreaks are very scary and hard. If any of you have children in this age group, I know everyone worries about this happening on their college campus. So this describes some of the recent outbreaks in clusters, and we say clusters because sometimes these are just 2 cases, and especially the 2 most recent outbreaks in clusters were just 2 cases. However, we also have some much longer outbreaks, and this one was 13 cases at University 3, and University 4 was 9 cases over a year period of time, and the 13 cases was over a 2-year period of time. What I don't show here is the number of students at these universities, but they vary. This large outbreak was at a very large college campus. The outbreak where 9 cases occurred was at sort of a medium to smaller size college campus. Some of these smaller clusters have been in very large college campuses, and some have been in much smaller college campuses with just a few thousand students. So this is another picture of Neisseria meningitidis, and what I want to show you here are the 3 vaccine antigens that are in the vaccines you're about to hear about. So NHBA, which is Neisseria heparin binding antigen, FHBP, and NAD-A. So these are 3 different proteins that are on the surface of Neisseria meningitidis, and these were targeted for these vaccines. Now, the reason why we can't use the polysaccharide capsule for serogroup B is because that is an antigen actually looks very similar to an antigen on to an autoantigen, so an antigen that we actually produce in our bodies, in our neurons. And so there's both concern that a serogroup B polysaccharide vaccine may cause autoimmune problems, but then there's also just in studies, in early clinical trials, it just didn't appear to show you didn't have an immune response because it wasn't recognized as foreign. So they had to take a novel approach to developing serogroup B vaccines, and they developed these protein-based vaccines. And this is really one of the first bacterial vaccines for which we've used these outer membrane proteins. What we know is that the immunogenicity of these proteins is not nearly as strong as the immunogenicity of the capsular antigens, of the capsular polysaccharides. And when we talk about immunogenicity in these next couple of slides, we're talking about serum bactericidal activity against the proteins. So we have two vaccines. One is called Trumemba. This is produced by Pfizer. It has two components. So this vaccine basically is two FHBP proteins from two different subfamilies. And this vaccine was licensed in 2004, and it was originally licensed as a 3-dose series at 0, 2, and 6 months. But as you can see in the footnote here, as of April 2016, it was licensed as either a 2-dose series if given at 0 to 6 months, or a 3-dose series if given at 0, 1 to 2, and then 6 months. So you still can't complete this series in a short period of time, but you can extend those 2 doses out and have it be just a 2-dose series. The reason why we have two different subfamilies is because these proteins have a lot more heterogeneity and differences in immune response as compared to polysaccharides, which are really well conserved across the different bacteria. So understanding how these vaccines work against the broad number of circulating bacteria that cause disease in the U.S. is really an important component of evaluating these vaccines. The second vaccine, Bexsero, is made by GSK. It's 4 components. One is the FHBP subfamily B protein. The other is NHBA. The third is NADA, and the fourth is POR-A1. And I wouldn't really focus too much on the names of these proteins. What's important to understand is that they're proteins, not polysaccharides, and there's much more variability of each of these proteins in terms of the different strains that are circulating in the U.S. This vaccine was licensed in 2015 for 10 to 25-year-olds, and it's a 2-dose series at 0 and greater than or equal to 1 month. So both of these vaccines were granted breakthrough therapy designations, and this expedites drug development and review by FDA. This was done in response, in part, to these increased outbreaks that were being recognized on college campuses. It brought a lot of attention to the fact that we didn't have a licensed vaccine. These vaccines were both in development and were still doing clinical trials, and so they expedited these approvals. So because they were expedited based on accelerated approval regulations, there's still a lot of information that we don't have that generally we would have prior to vaccine licensure. However, these vaccines clearly demonstrated immunogenicity to their reference strains. And what's important to understand about that is that these vaccines actually were tested against different reference strains. Because there's so much heterogeneity amongst these proteins, each vaccine used 4 different reference strains. And then when we say 84% of adolescents had a composite bactericidal response, it's 84% had responded to each of these 4 strains after 3 doses. And then the Bexsero, we have some different studies, and the range in terms of the number of adolescents who had a composite response to these 3 strains after 2 doses was 63 to 94%. And a lot of that seems like a wide variation. A lot of this has to do with where these studies were done. If these studies were done outside the U.S., where there was a lot more prior exposure to serogroup B meningococcal disease in countries that had much higher disease incidence, there tended to be a higher immune response to the vaccine compared to more serogroup B naive populations prior to vaccination. But the data do demonstrate that most serogroup B strains circulating in the U.S. probably would be covered. And we use word probably with caution, because this is all based on immunogenicity data testing done in the lab, and we have so few cases of serogroup B disease that it will be almost impossible to ever understand how well these vaccines are really working in the US. We're hopeful that in some other countries we can get some really good data. You have to remember that these vaccines use different strains and immunologic endpoints for licensure of each vaccine. So we really can't compare the two vaccines particularly well, but they did show good breadth of coverage, and the vaccines have shown some additional results to more strains, like 10 or 15 strains, but there's certainly strains of serogroup B disease that these vaccines do not cover. So I would, in general, I say these vaccines cover a majority of strains, but not all. The vaccines are reactogenic, but adverse events are similar to compared to other vaccines. So people do report pain, redness. Some adolescents would have a low-grade fever after. But it's pretty similar. I think people would say that these vaccines hurt was the biggest complaint from adolescents. And there was very low risk for, at least in the clinical trials, for severe adverse events. There is evidence for waning immunity in both of these vaccines, and that really contributes to the complexity of these recommendations. So Bexsero, only 66% of participants had a composite response to 3 strains 11 months after vaccination with 2 doses, and this was in UK students. So less than a year, even if more persons did initially respond, only a little bit above half of the number of adolescents vaccinated would be protected. To remember, 40 to 60% of subjects had titers 6 months after the 3rd dose. However, then it appears to kind of be a little bit more stable. We're waiting for more long-term data from both of these vaccines to really understand waning immunity. But once again, it's really hard to interpret all of this data in the setting of it being immunogenicity data and not real-life vaccine effectiveness data. So there were many challenges when considering routine use of MenB vaccines in adolescents. The proportion of serogroup B cases that could be prevented with MenB vaccines is really unknown. So the breadth of strain coverage is estimated, and we think that these vaccines show a good immune response to most of these strains, but what would be protective is really hard to anticipate. We also have constantly changing strains in the US, so what may be true from the last 5 years may not be true in the next 5 years. And then additionally, available antibody persistence data suggests limited duration of protection. Effectiveness data are not available. Initial data suggest no impact of MenB vaccines on carriage and nasopharyngeal carriage, so we don't expect there to be any herd immunity. And the potential impact of vaccine pressure on circulating strains is unknown. So one concern is that you could vaccinate against the strains that it protects against, and then the strains that it doesn't protect against could become more common. So ACIP had a really hard time with these recommendations. They talked about these recommendations for a really extensive period of time. The routine recommendations for persons at increased risk were pretty straightforward. So the same group of persons aged 10 years and older at increased risk are recommended for vaccination, including persons with complement component deficiency. And this includes people who use Solaris, because that basically, it's a monoclonal antibody that mimics a complement component deficiency. Includes functional anatomic asplenia and microbiologist, outbreak response. And we don't have any serogroup B vaccine preference. We don't have enough data to suggest that one vaccine is better than another. So this is a category A or routine recommendation, and it targets persons at increased risk in small populations. And we imagine that these people will need revaccination. We don't have enough data quite yet to be able to figure out when. But this is really targeting people who are at much higher risk and is a much smaller group of people. Note that for this recommendation, we don't include people with HIV. We don't have any data on how these vaccines work in persons with HIV. So that recommendation has not been made at the time. Also, the risk for people with HIV tends to be more serogroup C, and so we're still working out what the real risk is for serogroup B disease in persons with HIV. But for routine use in adolescents, the recommendation is a little more complicated. So we have a very low disease burden in 18 to 23-year-olds. We estimate about 30 to 50 cases with 4 to 7 deaths per year occur annually, and there are more cases in non-college students than non-college students. There are many unknowns about the vaccine, as we've talked about before, and so ACIP recommended you could, a category B, which is sort of our official language for what we're calling permissive recommendations. You could also call it a non-routine recommendation, and we probably need to do a little bit more work defining this language a little bit better. And what this means is that we do not recommend serogroup B vaccines for all adolescents routinely, but healthcare providers who would like to give it can give it, and parents who would like to get it, there should be access to this vaccine for kids and their parents if they choose to get it. The preferred age is that the first dose is given between 16 and 18 years. You should use the same vaccine for all doses if you give it, because these vaccines are totally different. And the VFC program up to age 19 years and insurance, these will be covered by ACA, which I'll talk about in just a little bit. MenB should be administered, if it is administered, as either a 2-dose series of that's the Bexsero, or a 3-dose series of Trumemba. ACIP is considering 2-dose series of Trumemba since that new change in licensure, and that will be voted on in October at the October meeting. But there's concerns about sort of which settings a 3-dose versus 2-dose series would be ideal for. Because the vaccines target different antigens, they're not interchangeable. And based on available data and expert opinion, these vaccines may be administered concomitantly with other vaccines indicated for this age, but at a different anatomic site if feasible. And as discussed before, there's really no product preference. So in summary, meningococcal vaccine recommendations target groups at increased risk, including adolescents. Category A, which is a routine recommendation for persons at increased risk, and Category A, routine MenACWY in adolescents, Category B for MenB in adolescents, and no routine recommendations for infants. There's a strong desire to protect against this devastating disease, but there's limited public health impact of routine vaccination, and that's really the struggle that ACIP had when they were making these decisions. It's, nobody wants to see a case of meningococcal disease, and fortunately, many young pediatricians really haven't had to see a case of meningococcal disease. But to implement such a widespread vaccination program in the setting of still very limited data and understanding of these vaccines did not seem prudent to ACIP. And so they felt like this permissive, non-routine recommendation was a kind of a nice balance of the public health versus individual decision-making question. So we are monitoring the epidemiology, circulating strains, and vaccine effectiveness, which is really important to ensure optimal impact of current vaccine recommendations. It's going to be really challenging with serogroup B in the setting of limited vaccine use, but we're hoping to collaborate with other countries and really pick areas where the vaccine may be more used. We're definitely following use of these vaccines in college populations that have had these outbreaks, and we've used these vaccines more widespread to see how well the vaccine's working. So now I'm going to talk just for a few minutes about understanding Category A versus Category B recommendations, and I think this was something we were particularly asked to address in this talk, so I wanted to give some background. So to make ACIP decisions, we use GRADE, which is the Grading of Recommendations, Assessment, Development, and Evaluation. And this is an evidence-based quality assessment approach, which was adopted by ACIP in 2010. And the key factors that are considered in the development of recommendations include the balance of the benefits and harms, the type or quality of evidence, the values and preferences of the people affected, and health economic analyses. And I want to point that out very clearly. There is no sort of point at which ACIP can or cannot make a recommendation based on the cost-effectiveness analysis. However, it can inform decision-making. And I like to say that cost-effectiveness analyses, really what they show you is impact, because any vaccine that has broad impact is going to be also cost-effective, really regardless of the vaccine price. And vaccines with more limited public health impact, will be, all of that information in terms of number needed to vaccinate to prevent a case is available through our cost-effectiveness analyses. So it's still very informative, but we don't have guidelines on decision-making around cost-effectiveness. So Category A recommendations with grade are made for all persons in an age or risk factor-based group. So in these settings, there's clear public health impact, and we have high confidence that there's a strong benefit for the patient, and the benefit risk balance is strongly tilted in the benefit category. And that's kind of what sort of how to describe the decision making in terms of deciding to do a Category A recommendation. Category B recommendations are made for individual decision making. So it's either a likely limited or an unknown public health impact. And for example, we made a Category B recommendation for HPV vaccine in males while we were waiting for additional information about the impact of these vaccines on male-related HPV cancers. And so that's an example of a Category B recommendation that was changed to a Category A when more data were available. But it can be, in the Men B decision-making, I think there was both likely limited public health impact, but also unknown public impact. So I think the group felt like there was additional information that was needed, but the impact of these vaccines broadly in terms of cases prevented would be very low. And there's also kind of a lower confidence in the benefit for the patient. And so there's no concern about risks in terms of vaccine safety. We think these vaccines are similar in terms of safety compared to other vaccines. We haven't given millions of doses of this vaccine, however, and there are risks. There are adverse events after any vaccine, and so we do know that there's a risk for anaphylaxis and other severe adverse events, all of which are very rare. But in the setting of a disease which is very rare, it makes the risk-benefit balance different than in the setting of a disease like measles, or a disease in which almost every person gets it, and it prevents many cases. However, clearly some individuals will believe very strongly that this vaccine has a very high benefit for them, and we wanted to make sure that there was access and availability of these vaccines for those persons. So this is a little bit more about the determinants of the category of the recommendation. So the higher the quality of evidence, the more likely it'll be a Category A recommendation. The larger the difference between the desirable and undesirable effects, the more likely a Category A recommendation is warranted. The greater the variability in values and preferences, or uncertainty in values and preferences, the more likely a Category B recommendation is warranted. An example is, what is the disease we're preventing? Or, I think meningococcal disease is clearly a very serious disease that I think the values of people is that, they would want to prevent it. There are other diseases which people, may not have the same values about, which may not have as much of long-term sequelae or long-term impact on a person. The costs, the higher the cost of an intervention, and when I say costs, I really mean resources, the less likely a Category A recommendation is warranted. And so it's not just thinking about the cost of a vaccine, but it's also the cost in terms of the amount of time in the clinic to add a vaccine dose to the schedule. It's the amount of time of it's the amount that it's the balance of other interventions and making sure you have high coverage with the vaccines that we do recommend. There's always a give or take when you add vaccines to a schedule that we are concerned about. So this is what the current 2016 vaccine schedule looks like, as you all probably have seen. And what you see with the meningococcal vaccine recommendations is that it's blue. So we have a new color for the schedule, and this color was talked about extensively at ACIP. But this light blue color shows that the range of recommendations for non-high-risk groups that may receive a vaccine subject to individual clinical decision-making. And so that's the only vaccine on the schedule that we have at this point in time. There is a Category B recommendation, I think, for among adults. There is for adults with diabetes for hepatitis B, but all children are recommended for hepatitis B. So how are Category A and B recommendations different in practice? Category A recommendations should be considered routine or standard of care. Most patients in the recommended age group or target group should get it. It's covered by ACA and VFC, and what that means is that insurance companies should cover it with no cost sharing by the patient. And we do have, remember, a separate VFC vote for these vaccines. So it's not that it's on the schedule, that makes it covered by VFC, but it's a separate VFC vote. But being on the schedule means that it's covered by ACA. Providers who vaccinate should stock routine recommendations, and that's kind of, especially VFC providers are required to stock all routinely recommended VFC vaccines. Category B recommendations are non-routine but safe to give and may provide benefit. So this is really a provider decision to recommend vaccine to a patient, and there may be patients who ask for the vaccine, so some providers may choose to strongly recommend it. Some may choose to not recommend it but give it if a patient asks for it. Some may choose to talk about it. Some may not have the conversation with their parent, with the parent and child. These vaccines are still covered by ACA, and there was a VFC vote to include this in the VFC program. And the guidance is that providers should either stock the vaccine or refer the patient if a decision is made to vaccinate. So understanding the complexities in stocking vaccines that may not be routinely used in the practice, the idea would be to refer a patient to a health department or other places that may have the vaccine if a provider chooses not to stock the vaccine. And that's my last slide. Thank you very much, and I'm happy to take any questions.
Okay, thank you so much, Dr. Cohn. I'm now going to go over some of the questions that people have. Let me see. So one of the questions is, can you use Men-B and Menactra together, or do you use one or the other?
No, you can give both vaccines at the same time, at the same visit together, preferably in different arms. But it is perfectly fine to give. The difference being all adolescents should definitely get Men-A-C-W-Y, and Men-B is really the decision based on the provider.
Okay, it looks like right now that's our only question, so I just want to reiterate to people that if you have any questions at all, you would submit them on the right-hand side of your screen. It's the control panel. You just would put it under the questions one. So just type it in and then click send all. Okay, so we have a question. Can a 24-year-old receive a Men-B vaccine?
It is licensed up to age 25, so a 24-year-old certainly could. It's not in the recommended age group anymore, but certainly in the setting of an outbreak on a college campus, a 24-year-old may very well be recommended to receive Men-B vaccine.
Okay. I do see a question about if people will be getting a copy of the slides. I just want everyone to know that I will be PDFing the slides for everybody, including a copy, a link to a recording of the webinar. Any other? Oh, another question is, just to clarify, meningococcal is in Group A or Group B. Is it required or is it recommended?
So ACIP does not actually require any vaccines. Those are really state mandates that determine which vaccines are required. That's very state dependent. But to clarify, the conjugate vaccine, Menactra or Menveo, are routinely recommended and on the schedule as routinely recommended vaccines. The Men-B vaccines, which are Bexsero and Trumemba, can be given. They're not routinely recommended, but it's not recommended not to, they can be given based on a provider decision to give them.
Okay, so Amanda, I know that you're national, so I do want to say that Illinois does require Menactra right now. It's a new rule that was just instituted early this year with this coming school year, and the requirement is that they need to receive 1 dose of it for students entering 6th grade and then 2 doses of it for students entering 12th grade. So that is the requirement in Illinois.
That's great. Thank you so much.
Of course. Okay, so it doesn't seem, oh wait, just got another question. So this question is, should medical students receive Men B much like microbiologists?
No, so people who are in the healthcare setting, including medical students or physicians, are not especially recommended to receive any of the meningococcal vaccines. And that's because microbiologists who routinely work with samples of Neisseria meningitidis or may be exposed, that type of laboratory work puts them at extremely high risk. We actually have had several laboratory incidents where people have been exposed to Neisseria meningitidis and have gotten the difference is they actually have very, very severe disease because the inoculum is so high. So that's where that recommendation came from. It's really people working in a laboratory and not healthcare settings.
Okay, thank you. So, all right, I'm going to, since it looks like right now there aren't any questions, I'm going to really quickly just go over some final remarks, and then of course if there are other questions then we can go over that really quickly. So, sorry, just getting my screen. Oh, I do have another question. It's, what do you think of the commercials on TV about Men B?
What do I think of the commercials? I think that the commercials, I think it's direct-to-consumer advertising, which, given that these are licensed vaccines, is certainly something the companies can do. Hopefully what they'll do is have people come talk to their providers, which really puts the onus on the providers about making the decision about whether to vaccinate. And we fully realize that this is not easy for providers, but it really was kind of the only, it was the only option that felt sort of like, I think it was just the most, it was kind of a compromise in some ways, I would say, between recommending it strongly for everybody versus not having it used at all. So I think hopefully parents will come and talk to providers and make the decision. But I do think it's important that people recognize that meningococcal disease is very serious, but the risk is incredibly low right now in the U.S., and we're seeing very, very few cases.
Wendy thinks that they are scary. That was her question. So, I'm gonna go ahead and start wrapping up this webinar then, since it doesn't seem like people do have any questions right now, but I just want to remind everyone that if you do have questions that you come up with, in the future that you think of, feel free to email them to me. My email, you'll be getting emails from me in the future about this, so just shoot one to me and then I'll try my best to answer it, and then of course if I can't, I'll be sure to reach out to Amanda or anybody else who will be able to better answer it. So I just wanted to let everybody know that we do have 3 more webinars that will be coming up towards the end of the year. We're going to be having one on October 17th about the flu to kick off the flu season, and then October 20th we'll have an eye care webinar, and then to round up the end of the year, we'll be concluding with another flu webinar just to give everybody updates on the flu for year to date. So So what's going to happen next after the webinar? Everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day today. Everyone has to complete the evaluation by September 2nd, 2016, and after this date, I will be closing the evaluation and you won't be able to complete it, and therefore that means you won't be receiving continuing education credit for that. And then about 3 weeks after that, you'll get your certificate of attendance and participation by September 23rd. It might be a bit earlier, hopefully. We'll see. So once again, I just want to thank Dr. Amanda Cohn for the excellent presentation, and to everyone else for joining us on today's webinar. And we hope that many of you will join us for our future webinars. So thank you, everyone. Thank you, Dr. Cohn. Have a great day.
Anne?